Guys. So I'm going to talk about composite restorations in primary teeth, the class 2 and class 3 fillings today. So let's go over them. Composite is kind of little difficult in primary teeth, not just because of the child's behavior. We have a problem, but it's also that they are harder to be placed in the patient's mouth, um, sometimes because of the technique sensitivity we have. My screen is not moving, so I don't know what's going on. Let me see if this can move. All right. So sorry, guys. Okay. So now the reason why composites sometimes don't work is because they are less retentive uh, as compared to on the permanent teeth because of the size of the teeth. So the restoration doesn't stay very well on on the primary teeth as it does in the permanent teeth, because the teeth are smaller in size, the pulp is closer to the tooth surface, and the enamel is thin. And so if the enamel is thin, there is less surface area for bonding, and obviously the child behavior. So there are a lot of reasons which make it difficult, the composite, to kind of stay in a child patient. So you have to make sure that all the factors are some of the factors are in your favor when you're doing a composite on a pedo patient. Otherwise, it's not going to last very long. Um, a few times I have done composites on patients where I feel like the tooth is going to shed, the patient and the parents just wanted composite filling, and I'm okay if it doesn't stay too long. But you very technique sensitive, so you have to be careful. And again, the material does not retain well in the primary teeth because of all these factors, being the enamel is thin and the teeth size is small and the pulp is closer to the tooth surface. So all those reasons cause the problem. And then there is lower bond strength in primary teeth because of less mineralized dentine, thicker hybrid layer that is not completely penetrated by the bonding agent, different microcrystal arrangements, and the prismless layer that does not respond well to acid etching. So if you remember, the enamel has these prisms which help us for acid etching. Now, enamel is what etches well and helps us to bond the composite. Now, when the enamel is thin, so we don't have enough surface area. Secondly, it's prismless layer. So again, there is not enough for the etch to happen. Those factors lead that the enamel is not greatest situation for us for etching. And then dentine, less mineralized dentine, the thicker hybrid layer, which prevents the bonding agent to go in. So all those factors just doesn't make our life easy. And then on top of it, don't forget the child and the child's behavior. And then sometimes parents are very demanding too. So it makes life difficult. So we have to keep all these factors in mind. But if we can do it, then we should do it because it's aesthetically good. Now, certain reasons, certain indications where we can do the composite fillings, we are when the filling is small in size. That's a basic point. But if it's going to be a big filling, or the patient has a lot of cavities and it's a high risk, caries risk patient, you don't want to do too many composites. This patient is not taking good care of his teeth. So, composites are not going to last. My personal experience has been that composites has a lot more decay under them than amalgams. So a lot of times when I see patients with a lot of decay around their teeth, I would go ahead and do amalgams and glass ionomers. Don't play with composites on those patients, even if they are cooperative. Glass ionomer does release fluoride, so that's helpful. So that's one positive point about glass ionomers. So now the few cases when we can do composite is a simple class 1 cavity. It's an occlusal surface caries which extends into the dentine. A small cavity class 1 which is in the dentine. Simple, easy, go ahead, do the composite. A class 2 restoration which has a small box and it is not extending too much in the proximal line angles, pretty conservative, and patient is good and you can handle everything. There's not too much bleeding, not too much moisture, we can do it. Then in cases when the tooth is going to exfoliate soon, within 2 years, a class 2 restoration, you can do it in that case. But if you want the restoration to last too long, sometimes, you have to be careful. And a lot of times you just keep monitoring the fillings and then see if you have to replace them. So the best is the follow-up with the patient. And then class 3, class 4s, and class 5s. Those are all anterior teeth. Nobody wants a amalgam fillings, obviously. So we're not going to do that. Now, in those cases, you kind of have to go with your judgment call of glass ionomers or composites. And I think I gave you a good indication of which one to do when. So child behavior is first thing. If he's not that cooperative, switch to glass ionomer. If there is moisture, bleeding, subgingival, switch to glass ionomer. Easy and simple. Otherwise, you can go ahead and do composite filling. So few reasons, few cases where they are contraindicated, that we shouldn't do it, where a tooth cannot be isolated to obtain moisture control. Remember, moisture, moisture, moisture. It's very critical that there is no moisture close to composite filling. So if you can't control it, don't do it. We sometimes feel like, oh, it's just little bit bleeding, let me just do it. I have seen them fail. They don't work, especially the class 2s in the proximal box. I have done once in a while and they have been a failure. So please don't play with it. Then second is large multiple surface restorations in the posterior primary dentition. So in the back teeth, if there are big lesions, don't do it. Go ahead and do a glass ionomer, and then on top of it, go ahead and do a crown, a stainless steel crown or something like that. And then patients who have a lot of caries, there is demineralization, they don't have good oral hygiene. I think those patients are perfect candidates for glass ionomers. Just do glass ionomers on them and monitor it, watch it. They need to come on regular basis. Give them lots of fluoride. I love Act mouthwash. I give it to all my patients. I tell them, it is one of the best thing. Act mouthwash is one of the best thing because with Act mouthwash, they are only putting it in their mouth and they are not taking it inside their stomach. So I don't like giving fluoride tablets anymore. I don't give fluoride tablets to any of my patients. And so I just stick with Act mouthwash and I tell them, get the flavor you like. And in the night, after you brush and you floss, use just the Act mouthwash around your mouth and then sleep. And then I also monitor one more thing is which is zip code they live in. But there are zip codes which have very good amount of fluoride in their water, some don't. So you please monitor that too when the patient comes. These are very important when the patient comes, talking to the patient, how much cavities does the family members have? Does the mom have a lot of cavities? Do the siblings have a lot of cavities? What's going on in the family per se? Do grandparents have dentures? Genetics is a big factor which could determine how their teeth structure is or how much cavities they could be prone to. So just talking to the patient, knowing them, is very good. The second thing which I really like is telling them that nobody can avoid candies. We live in an age where it's Halloween or something or the other happening, Christmas time, Thanksgiving. We love our candies, we love our sweets. So, we have to be realistic. Everybody is going to have sweets. So, what I tell my kid patients is I'm not saying you can't have candies, but have them at one specific time. So that way, if we don't do interval exposure to our teeth, it's better than doing one time exposure to your teeth and then letting it sit for a few minutes or 5-10 minutes and after that going for a brush. Also, I tell my patients that brushing your teeth, you need to wait for 30 minutes before you brush your teeth after eating food. The teeth are soft and you don't want to brush your teeth right after you have eaten food. So those are a few important tips which over the time I have learned through various seminars and by my clinical knowledge. So wanted to share those with you. One more tip is xylitol gum. Xylitol gum is really good for patients, all kinds of patients. What you tell them is, especially after lunch, put xylitol gum in your mouth, chew it for 1 minute, and then spit it out. So all that stuff which was stuck in your teeth will get out of your mouth. Your saliva content will increase because remember, a lot of medications like Claritin and stuff are causing dry mouth. If the patient had been taking those and then they had dry mouth, the xylitol is going to help them increase their saliva in their mouth. So, you've done twofold work for them. And really, the truth is, everybody is so busy. Lunchtime, it's really impossible to brush teeth. So, xylitol works great in those kind of cases. Anyways, I want to come back to composites now. So let's talk more about composites. So we went over the contraindications where, people who have lots of caries and don't have good oral hygiene, let's stick with glass ionomers for them. Now, when we are doing class 3 restorations, for composites, like we always do, we want to drill the minimum. There is bonding, so we don't need to drill more than we have to. But remember, primary incisors, you have to place a dovetail because you want to increase the bonding area to enhance retention. That is the reason that we want to place dovetail in class 3 restorations of primary incisors. So extra mechanical retention due to weakened bonding. That's the main thing. And you remember why the bonding is weak? Because the enamel is thin. The enamel doesn't have those prisms. So it's prismless enamel. The bonding, the dentine is not mineralized. So all those reasons that cause our bonding not to work well. So you want to get that extra mechanical retention in class 3 cavities. Beside the dovetail, you just remove just the caries and then proceed with the filling. The procedure is same as permanent teeth, the class 3. You focus on isolation, again, no moisture, and good bonding technique. And in the kids, you can try to do facial, go from facial because it's easier. It's harder, to go from the lingual. But, we try to do lingual because kids are also very conscious. So, and then we go do the filling as we always do, etch, bond, and then, place the mylar, wedge, and then we bulk fill it. Depends upon how much we have to fill in each layer. Now, this is a clinical case from Ultradent. Now, in this case, if you see, they have placed cords, and because the decay was deeper going subgingival. So they placed cords and they got the area dried pretty well. And there is no moisture and stuff. So that works good. Now, in this case, one more thing which would work good is laser. So I think this is like older slides, but if it was now, I would just do laser, like just trim the gum a little bit and then just do laser. And laser is amazing. And then the extra growth of the gum is also gone. And then you just place composite or glass ionomer, depending upon what you can, what is right filling at that time of when you're doing it. So look how nice it looks. Actually, it looks pretty good. And here we are talking about the Denvometrics ring and wedges. So basically, everything is almost same for composites, for amalgams, and for even for glass ionomers. I do a lot of glass ionomers in permanent teeth too. So everything is mostly same. You have to focus on isolation, on bonding. You have to do minimal prep for composites so the tooth can last longer. Uh, just glass ionomers are more forgiving, so you can do them. And what I have seen clinically is I've done glass ionomers and the patient comes after a year, they look great. I don't have to do anything. Honestly, previously I was replacing my glass ionomers with composite fillings. I've stopped doing them. And I just, if the patient is regular, they are coming to me, everything looks good, I just let everything be how it is. So now I'm going to talk about space maintainers.